Missed our latest webinar? No worries. We know life gets busy, but your professional development shouldn't have to wait. That's why we've created webinar micro lessons. Short, focused recaps of our full sessions designed to help you catch up quickly and still earn your CP points. These bite-sized lessons are available exclusively to active subscribed members. So even if you miss a live session, you never miss out on the knowledge or the CPD points. Not subscribed yet? Now's the perfect time to join. Get access to all future webinars, every micro lesson and more. Visit www.clinicalcareplatform.com to sign up today.
Good evening, colleagues. I think we are a little bit too early, which will be unfair for our other colleagues. Yeah, a warm welcome to you. It's like 2 minutes before. Maybe let me play the ECG. I don't know what to call it. Clip. And we buy time for some of our colleagues to still join. I don't know. I thought all these intro videos would play at least until past. It will be unfair if we start now. Are you good, guys? Are you good? Can you give me a sign that you are here with a thumbs up or something along those lines? Yay. All right. Yeah. So let me play something for you just for 2 minutes or so, and then we will start. This is Doc.
Yeah, today I'm a bit excited, so I'll ask more questions.
So it's time for us to see this in action. A beautiful 12-lead ECG, right? We're going to take about maybe 5 seconds just to stare at this ECG and try and decipher what's going on. All right. So here we have it. List the main abnormalities. We see beautiful ST elevation in the inferior territory. 2, 3, AVF. Boom. Very nice. But that's not all we see. We also see ST depression with inverted T waves in lead 1, right? We also see it in AVL. There we go. And in V2. Hello. This is what we call reciprocal change, right? We are infarction in one area, and looking at the heart from another angle, we see ischemia. We took that same ECG and we flipped it around, right? And if we read this ECG from right to left, then what was ischemia, as in 1, AVL, and V2, now looks like ST elevation myocardial infarct. If we look at what was infarction in 2, 3, and AVF, if we read it from right to left, now looks like ischemia. That is the beauty of the electrocardiogram, because guys, we're looking at the same heart, but from different vantage points. Hence, we use the term reciprocal change. So this is an inferior myocardial infarct. But in the anterior territory, we have ischemia. That's reciprocal change coming from the inferior event.
Yes, colleagues, that's what we are going to be busy with this coming Saturday. Like I said, I think it was yesterday where we had the information session. I said after watching that clip, I'm like, I don't know what's going on there. I just see all sorts of graphs going up and down. And if you are like me, maybe you should be joining us this coming Saturday. If you are very good and you could figure out what Dr. Ryan is saying, maybe you'll be excited to join him on Saturday and add value to other colleagues who are like me, who only know ARVs. But yeah, all in all, that's what we are all about. Yes, so welcome to the Clinical Care Platform. This is a time for our I always say you have to be better. You want to improve, you want to grow every single day. But to grow tomorrow, you have to commit to developing yourself today. So we give you this opportunity to do exactly that. Let me switch off because I hear my iPad also has some audio. Yeah, so just to say thank you very much for your commitment to continuous professional development. This is very, very important. And it is this kind of things, that require us to make trade-offs. Nothing great happens downstream. Everything is uphill. And to be here tonight, there's something you are trading off, either your family time or your own time or the time that you should be connecting spiritually, but you have decided to join us. So we don't take this time for granted. But with trade-offs, it means you'll achieve more and you'll continue to grow. I'm not alone as usual. I'm with Ngobile. I can't do the Qs, ne? Q, C, X, C, because in Northern Lesotho, we don't have any words that
I know.
have...
It's not in your vocabulary. I'm so worried.
I really tried to say I'm gonna say it slowly, and it's just
No,
there on
no.
my heart. Yeah, it's refusing. But Ngobile, Ngoma, yes. Are you well, Ngobile?
I'm good, Nyaka. I'm well. Thank you. How are you?
No, I'm good. We are so happy to host you. We didn't test your camera, but if it's working later on after I've shared my slides, maybe colleagues would like to see who they are talking to. In the meantime, let me just do some couple of intro slides. But yeah, just to say welcome to you, Nobile, and also for making time to join us here at the platform. Colleagues, today we're discussing how to transform TB care, particularly looking at how you can optimize TB diagnosis and detection. And we know drug resistance is continuing to be a growing issue in as much as we have better regimens, but we really would prefer that no one gets TB, especially if that TB is resistant. As a platform, we have a mission to improve patient care, and this evening session aligns very closely with our mission to do exactly that. So stay put. You are going to be empowered, and we want to see this translating to better patient care. Look on your right and tell me, what do you see? We have now issued over 120,000 CPD credentials. We were celebrating 100,000. Now we have 20,000 more. Colleagues, this is worth a celebration. Please, celebrate with us, even if it's an applause. And let me find that DJ horn. There we go. So, in life, you must celebrate every single step, every single milestone, because life is not easy. You can see those dots are uphill. So it means there's always, pressure to push you back where you come from. But we keep on pushing. And this is not possible without you, our members, supporting us as a platform, but also collaborators like Ngobile Ngoma. I was played, the cue there. But also her employer, Surfeit. I think she'll tell us a little bit more about her work. We really want to also thank them for allowing you, Nobile, to share your knowledge with us. If you're not a member of this platform, visit our website and you'll see that there's more value for you. And yes, our diploma preparatory programs are now open for registration. Live coaching will start in October, so you have enough time, to plan. If you want to write your exams next year in February, this is an opportune time for you to make that investment. Just to also make you aware, if you are planning to write the HIV management diploma to be accepted by the college, you must have completed your basic and advanced HIV management courses, which are included in the program. But then if you don't have those two credentials already, I would really recommend that you register, you complete those, so that when we start the coaching program, you are done. And when the registrations open, you are not under pressure. The same applies to the diploma in child health. You will be expected to complete the IMCI, Integrated Management of Childhood Illnesses, as part of the requirements to be accepted to write these two diplomas. So I want to encourage you to register early, complete them, so that by the time registration opens, you are not under pressure to complete either of these two. And yes, this coming weekend, we are with Dr. Ryan Sepesat. We're going to be looking at those difficult graphs. So please join us this Saturday. I'll share the link again later on. And yes, our academy is growing. We have a number of self-paced e-learning modules, from dispensing license to NIMAR to cardiology, nephrology, all are sorted just for you. But let me not bore you, as always, with my multiple. They say death by PowerPoint. Let me not do that to you, but to appreciate this evening hosting Unobile Ngoma. And I see there, I think there was a mistyping there of the topic, but we are going to be discussing how to transform TB care by accelerating timely diagnosis, but also to ensure that if there are patients who have drug resistance, we can timely diagnose them so that they can get appropriate care. And here it is. This is our instructor. We welcome you back. By the way, some of you might think that Unobile is new, but when we started this platform about 3 years ago, she was one of our first speakers. You can read her profile as much as, but I can tell you what I really, really appreciate about her. It's her pursuit for her own professional development, having, done her master's program. And now I think she's pursuing a doctorate in the same field. And you can see she likes implementation science, and her affiliation with some of the international universities there, UCL and also Washington University. She currently serves as a senior clinical solution executive at Surfeit, and I think she's best positioned to tell us a little bit more about that. But I know she's an epidemiologist, she's a public health specialist, and now really focusing on infections. I know her as someone who's an advocate in the public health space, especially issues around youth, adolescents. And it's also positive for me, Ngobile, to see your career trajectory, growing at this pace. And we just want to appreciate you for always encouraging us to not stop and freeze where we are, but to continue to develop ourselves. A warm welcome to you. Can I hand over to you to share your slides and say hi to the colleagues? And yeah, if possible,
Yes.
I'm hoping they can see you, but you let us know if you're in a safe environment for that.
I'm still in the office for
Oh,
this call
awesome.
today. dedicated. I'm still in the office.
That
Thank you so much for having me. I'm just going to switch on my camera for now so that we can at least put a face to the voice. But through the presentation, I'm going to ask to switch my camera off. So just to save up on the bandwidth and to minimize the interruption we may have through the presentation. But as I've said, and yeah, I love being here and I'm happy to be here once again. I think I was last here a few years ago, and yeah, I've had a number of sessions in this platform, and yeah, I'm just glad to be here again today. And today we're definitely going to be talking about transforming the TB care. I don't know, because Naga spoke about my role. Maybe I can just briefly mention that before I start presenting. So as he mentioned that I'm at Cepheid now. Cepheid is a molecular diagnostic company. So we're basically manufacturing, as you can see behind me, there's a gene expect assay. There's a test behind me. I'm sure everybody knows gene expect very well from our lab forms, though maybe some of us haven't seen it since we are clinicians. So I'm at that company that actually manufactures those gene expects. Our tests, the gene expect are used from TB, as everybody knows, but beyond TB, we have more than 30 tests that we are actually running on the same TB platform that you have in every hospital. But for the sake of today's presentation, we're only going to talk about gene expect in the context of TB. So I hope to come back and have other of my colleagues sometime ongoingly to talk about other platforms or other assays or other tests that we have that also impact the infectious disease space, as well as there's oncology as well involved there. It's so interesting. We have so much that we're able to actually assist the public health. But without wasting time, I'm going to ask to switch off my camera so that I can start presenting.
awesome,
Naga,
awesome.
please give me a go ahead.
Yes, just to check your audio, there's some small feedback. I'm not sure if you have connected anything on your computer for sound. Have you joined with only
Not at
one
all,
gadget?
just the screens. Yes, yes.
Okay.
There's just a screen, not unless I can disconnect my screen. Let's see.
Yeah, I don't know if your laptop draws the audio from the screen or from the laptop directly. Can you talk now? Let me hear how it's going. Hi, Ngobini. I think we have lost you. So it means you are drawing audio from your screen.
Can you hear me now? I see internet unstable. I think that's why I asked to switch off the video, but I hope it's gonna work out now.
All right. I think let's continue. It's fine. Colleagues, you let me know if the audio is not at its best. There's some tweet, but it's fine. I think we can cope. Yeah. Thank you. Thank you, Ngobile. We can see your slides. Everything is perfect. Thank you.
Okay. Okay, yes, again, Police is going to talk about how do we accelerate the TB care from, disease management perspective, and mainly the role of molecular diagnostics, because, we all know that screening or preventative care starts with accurate diagnostics. So that's where we're going to begin. So as I start, this is going to be the outline of my presentation. We're going to start reflecting of the epidemiology of the disease globally as well as in the country. We're going to look at the guidelines for TB diagnostics and TB diagnostic algorithms and TB treatment. I'm not going to go much into treatment because I want us to mainly focus on the preventative care of the disease, and then we're going to conclude. I'll try to be short in contradicting with my actual height. So before we go into my presentation, I just want to comment. I was actually very happy to come and talk here because I know that I'm speaking to clinicians and majority of the frontline clinicians that are seeing TB patients day to day, and they are consulting and in the forefront or boots on the ground in this TB epidemic. So the Gene Expect nationwide was rolled out. We know that it's over a decade now. And when looking at data from 2011 to 2023, South Africa has made a significant progress actually in managing or averting the TB epidemic. So we have together with you guys averted over like $1 million. These are disability adjusted life years, which is a measure that measures say premature death or the life that is lived with disease or disability. So if we are able to manage this disease early and we are curbing the disease and we're preventing early preventable deaths as well as the lives that are lived with disease. Therefore, we are together, contributing to productive lives. And big up to everyone in the call. And we have reduced also the TB incidence by over 50%, which is very significant as well, and became the global benchmark for decentralized care and bridging the health equity. We know that there is no universal healthcare coverage or health equity except for decentralized care. So in South Africa, we became the benchmark globally that actually mastered that model in the context of TB to decenter or to have our diagnostic test also embedded in all the peripheral hospitals or healthcare facilities, therefore availing the diagnostics that informs the clinical decisions and therefore impacting the patient's lives positively, especially
Hi,
to
Ngobile.
those.
Just to check, which slide are you on?
Oh,
'Cause I don't.
I'm still here.
You're still on the agenda slide, right?
Yes, yes,
Oh, okay.
yes.
No, colleagues were
But I was
typing.
still giving.
They were hoping you are
Oh,
moving. Okay, I
okay.
want to give them proper feedback. Thanks. Sorry.
Okay. No. I was still giving you compliments on what you have done before we go into my presentation. So I'm still on the agenda slide. I'm aware of that. I'm so sorry to confuse you. Anyway, we together contributed to early diagnosis and treatment. Therefore, we reduced the product. We promoted productive lives and reduced the productivity losses. Hospital costs and long-term disability, we all contributed to that together. So again, big up to you. And I don't know if you guys know, but I believe some of you should know that our Minister of Health actually had even won multiple international awards that recognizes the country or his work, his leadership in the country in TB control. So again, big up to each and every one of you in the call. So I'm saying this because I want us to continue holding hands and fight this TB battle because it is far from over. So we're going to start now jumping into the TB disease burden first. So in this slide, we're reflecting first on the global matters. We can see that the TB mortality was estimated to be by 2022, 1.30 million deaths, and the incidence was estimated to be 10.6 million. And the TB case notifications. We know that TB is a notifiable medical condition. This was 7.5 million. And the MDR, which we are all worried about, and we don't actually want to see it because it talks to the failure of the healthcare system to combat the infection, or the failure of compliance to make treatment, but it's a complication of TB anyway. So this was estimated to be 410 for 10,000. Yeah. 410. So as you can see, this is mainly the global estimates and for 2022. But when we zoom into the country, we know that between 2023 to 2024, South Africa has recorded 270,000 TB cases. This includes 13,000 drug-resistant cases. So let's keep that in mind as we proceed with the other slides. And the incidence in the country between that year, 2023 to 2024, was estimated to be 427 per 100,000. And we had almost half of these, 48% of these TB cases in the country were co-infected with HIV, which makes it important for us to know how to manage, especially those that are infected with HIV. 79% of these cases were treated, and 56,000 actually succumbed to TB. So TB continues to pose a public health concern in our country. And for clinicians, especially the frontline clinicians, especially the primary health care and secondary care, we know that we get to have to see much of these cases. So we are looking at the TB disease over time. And in this slide, we can see that from the year 2000 to 2022, there's been global TB deaths declining from nearly 2.5 million to under 1.5 million. So there is that significant decline of these TB deaths, while the new TB case rates also dropped across these regions, with Africa and lower middle income countries still continues to carry the highest burden. So we know that in the global south, we are actually carrying the higher burden of infectious disease in general. But in this slide, we can actually see that it confirms that we are making progress. There is significant progress, but we can still fight and continue to fight this battle. So right now, we are looking at a study that looked into undiagnosed and missed active pulmonary TB during the mass gathering. This is a cross-sectional study. And in this study, in the cross-sectional study that was conducted in H, it found that 0.7% of the non-hospitalized and 2.9% of the hospitalized international travelers that were attending this gathering from high TB burden countries, they actually had active TB, with 78% of the hospitalized cases being missed. So it talks to, we know that, traveling history or traveling itself, also it is a contributing factor or risk factor when we're talking about TB, especially if you're traveling from the high burden countries. So this underscores the need for better screening. So we need to ensure as countries and member states to say we have our screening protocols and we have our screening practices on point so that we can catch even these traveling cases and curb the TB as it enters in any region to actually prevent the transmission in our communities. So in this slide, it's still on migration and TB. So the slide really underscores that nearly half of TB cases that were determined in COM between 2018 to 2022 were among the Afghanistan immigrants, with about 42% latent TB infection prevalence across this region. And again, this raised concerns about TB reactivation and its potential impact on MDR or rifampicin TB control. So this really also still confirms or supports the previous study to say migration and TB it has that strong association, and we need to be mindful of that. So after we have looked into the burden and the state of affairs, and we know where we are sitting in the country and what we should be cautious of, where is the gap, or why do we still see, for instance, that 13,000, we said in South Africa, we counted 13,000 MDR cases, and we still have those 56,000 deaths for TB. So there is a significant gap in diagnosing TB or getting the cases early. So in 2022, about 10.6 million people developed TB globally, but only 7.5 million were diagnosed. This leaves about 3.1 million undetected cases. And this is what we need to keep in mind. So while just 47% of undiagnosed patients received repeat diagnostic tests. So again, less than half of these people had received the repeat diagnostic test, which is the test that is endorsed or recommended by the WHO that we should be using for TB. But the interesting part is that 3.1 million of these cases were undetected. So there's that problem as well in our country, because as of 2023, South Africa had faced, as I mentioned before, the 66 undiagnosed TB cases and 13,000 MDR cases. 48% of these people lacked access to rapid molecular TB testing. So we know that we have transformed the healthcare system as far as the TB is concerned. We have availed decentralized care, and we are ensuring that we are pushing and actually making progress towards health equity and serving the underserved. But that's a significant gap that still exists that we need to be aware of, that there's still majority of people that are not receiving diagnostic testing or rapid molecular diagnostic testing, and therefore we still have significant proportion of people that are actually developing MDR TB and succumbing to this disease. So why should we care? I mean, we are all fighting this battle together because there is a global plan to end TB. And this is very important. From 2023 to 2030, we are planning together to say we should be working towards ending TB. This has to be done through scaling up diagnostics to care priority actions. I mean, the global plan to end TB, prioritizing scaling up these modern diagnostics, early and integrated TB screening, and people-centered digital surveillance and support system to reduce the missed cases and treatment barriers. So it starts with accurate testing that we have to conduct to the right person, the right test to the right person, so that we can initiate treatment early as possible. ideally, same consultation, the patient has to have the accurate results, if it's positive or negative, and the results has to give us an idea on what treatment do we need to give this particular patient. So this is key in us actually achieving this goal that we have set for all the member states in this world. So this is just to highlight again that scaling up the use of modern diagnostics is one of the priorities that is being set up as the plan to end this TB. So there's a cost of inaction if we don't really continue with our plan, or if we don't fight or continue the end TB plan, there is a cost to that. So the global fund, global plan, excuse me, to end TB, if it's not implemented, it means 43 million more people would develop TB by 2030 if we don't do anything, if there's an inaction or we don't put measures in place and follow up on those measures and change our practices and actually do something about ending TB. It means by 2030, we will be counting 43 million more people that would have had TB and resulting in 6.6 million additional deaths, according to this study. And that talks to also the cost, the overall cost to care, overall cost to lives as well. And I mean, it's going to also be affecting life expectancy and our economy and everything else. So we don't want to go into that devastating state of TB that we have worked so hard actually to achieve and get to the progress that we've made today. So now we have laid the background on why we need to do something about TB. So now let's go directly into the diagnostics. So the slide here, it really outlines the WHO endorsed TB diagnostic technologies. We know that we have a wide variety of diagnostics. They are countless and they differ according to characteristics. And we know that we as clinicians as well, or as healthcare specialists, we are guided by the WHO. So the WHO has released these consolidated guidelines on tuberculosis diagnosis. So it has the different tests from the NET, LPAs, and LFLM, and targeted next generation sequencing with new chapter added for sequencing-based tools to improve the drug-resistant TB detection and support elimination goals. Excuse me. Again, for us to achieve the elimination goal, it starts with detection. We need to have the right tools in place and use the right tools timely. There's nothing that's as precious as time in clinical medicine, because you want to have your results in timely manner so that you can cap the transmission or the progression of disease. So getting your results today and getting them in 3 days or in 7 days do matter. So that's why we have the WHO that is also guiding us. And this guideline actually has all sorts of relevant diagnostic technologies that are relevant and that are endorsed or recommended for TB diagnosis. So I'm going to take you through basically the recommendation on the subsequent slide. So the WHO recommends using the Expect MTB-RIF or the MTB-RIF Ultra. I'm not sure if colleagues are aware of this, but I think you are writing them on the lab form every day. I trust you that you actually do. These are the GeneXpect instruments or the GeneXpect tests that are used to detect TB. So WHO, it actually recommends using the GeneXpect, whether it's MTB-RIF or MTB-RIF Ultra. As you can see, the cartridges on the right-hand side, they're talking to exactly that, as the initial diagnostic test. So according to WHO, this is the primary diagnostic test that we should be using. Because, I mean, the MTB-RIF Ultra is also giving us not just the TB results, also the rifampicin-resistant results in adults with pulmonary TB symptoms, with strong evidence supporting its accuracy over smear microscopy and culture. We remember that back in the day, I mean, we used to rely mainly on the smear microscopy or culture, but currently with, as time goes by, as technology improves, I mean, we also are adapting in a new way and modernized way of identifying disease. So that's why the WHO currently is recommending that the GeneXpect should be used as the primary or the first choice for countries when we are looking for TB. So these are mainly also still the guidelines. The WHO 2022 consolidated these guidelines and operational handbooks. They provide updated practical guidance for diagnosis and managing of tuberculosis in children and adolescents, and incorporating all recommendations from 2014 to 2022. So these are also guidelines, because the other ones were for adults. This one is mainly for children and adolescents. So the clinical utility of Expect MTB RIF, this is, remember, the Expect MTB RIF is mainly the name of the test, or the Gene Expect test, that is primarily endorsed or recommended by the WHO. So WHO really recommends this particular test to be used as an initial test for TB and rifampicin resistance in adults with pulmonary symptoms, showing improved outcomes, including 7 fewer deaths and 18 more cures per 100,000 patients compared to smear microscopy. So in this study, that's where they actually found, or their results actually confirmed the superiority or the preference of the Gene Expect compared to the initial smear microscopy or even culture. So these are also some of the studies as well. This is a systematic review. They also looked into using the Ultra MTB RIF Ultra. So it still talks to the superiority or the performance, the clinical impact as well of using MTB compared to other tests, and how is it superior. So this is rifampicin resistant TB. Still, the Expect MTB RIF Expect, we did reflect on this to say it actually is recommended by WHO to be as first line, because it's going to give you the results for both TB and rifampicin resistance. And so this study also was estimating the effectiveness of rifampicin resistant tuberculosis diagnosis by the Expect MTB RIF assay on 2-year mortality. So as clinicians, I know that obsession, or myself included, when I hear about any intervention, what I want to know is how does it impact how soon the clinical decision must be taken, or how does it impact, clinically, the clinical actions that has to be taken, the economic aspect of things, how much are we going to be saving if I'm employing whatever intervention that is brought forward. So the economic evidence of molecular assays is also included in this guideline by the WHO as well. So this was compiled by reviewing 28 studies globally that found that the Expect molecular assays are generally cost-effective for diagnosing TB, especially in high prevalence areas among people living with HIV as well, which we know that these are our key people, especially in the context of TB, and where empiric treatment is low, though outcomes depend heavily on the implementation conditions. And these conditions, they would include, but not limited to, the existing infrastructure, other labs and trained staff already in place, how decentralization has been employed, the testing strategy, empirical treatment rates, linkage to care, and other implementation measures. But we can see that according to this WHO, in this review, they found that using Gene Expect was found to be cost effective. Part of it now, I'm adding to what they had found. Part of it is because, as you know, that with your Gene Expect, you get your results within less than 2 hours. And as much as you can reflect, say your MTB RIF is positive, you are reflexing to the XDR1, or altogether, you're still going to get your results. You are still able to test and treat, for instance, on the same consultation. So that has an impact as well in saving. There's, especially in remote areas, there's a thing that you have to send a patient home and they can come back for results. So you're eliminating that as well. And when they go home waiting for the results, they can transmit whatever they have. So you know who to isolate. It informs your clinical decision at that point. So if you're getting your accurate results at the point of care, it doesn't only empower you as a clinician, but it also, benefits the same patient. So now let's look into the diagnostic algorithms. Before we go to the algorithms itself, so this is how the Gene Expect machine looks like, especially the clinicians that have never been in the lab. So we have Gene Expect machines. as you can see, it's the exact same machine, it just differs in size. So this is how scalable the machine is, because it depends where you are. If you're in a bigger hospital at a central lab, you're going to use the biggest size. If you're in a mobile clinic, for instance, or primary healthcare clinic or hospital, or even in doctors' rooms, you are employing a size that's relevant for that particular space. So it's the exact same machine that's scalable to every healthcare space, from central to decentralized or near patient testing, and we're using the exact same cartridge. As you can see, the cartridge is on the smallest machine that you see, is the same cartridge you see again on the biggest machine. So it doesn't compromise the standard or the quality of the test and the results that you're going to get, because these are automated PCR tests. So yeah, and it's definitely one platform. When I introduced myself, I said we are able to run more than 30 tests, not just TB. TB is just one. We run more than 30 others that we're going to talk about in them later on, not now. But yeah, this is the power of, the good thing about the GeneXpect, and that's how it's easily employable, especially in decentralized settings. So now let's jump into the integrated pathway of the diagnostic algorithms. As you can see, the reference again this is WHO. So in this image, it summarizes basically the 4 endorsed TB diagnostic algorithms. There's algorithms that's, as you can see, it talks to the molecular WHO recommended rapid diagnostic tests as the initial test, the one that we just spoke about in the previous slide. And then there's LF-LAM for people living with HIV, especially those that are not able to produce sputum, and rapid drug susceptibility testing for fluoroquinolones. I need water now. And betaquilin in rifampicin-resistant TB, and additional resistance testing for rifampicin susceptible and isoniazid-resistant testing. So this is basically the WHO and the different algorithms that they would advise, obviously, and it's applicable or it depends on the setting where you can, apply what is applicable to the particular setting. So it's different tests for obviously different circumstances and different settings. So we know that in the country, as much as WHO is recommending the first line testing to be GeneXpect, also in the country, that's what has been standard practice over years. And other tests are also used in obviously different circumstances. So this is again another peripheral setting pathway. This peripheral setting with high isoniazid resistant TB, the expect detects rifampicin resistance first. As we did mention on the previous slide, that the GeneXpect first line testing is going to give results, obviously, for rifampicin resistance as well. Even according to this WHO pathway, then it's getting to be reflexed to check on the isoniazid resistance and enabling tailored treatment without needing centralized lab. So it's the WHO recommends decentralization, of course, so that we can minimize the traveling of specimen from one point to the next, and also for sending patients back and forth, or for misdiagnosing or missing people, because sometimes the loss to follow up happens as the people have to wait longer, or they have to come back and all of that. So that's why we lose them on care, and we still have a significant proportion of people that are not treated and that are actually not, they are missing on the healthcare system. So these guidelines are mainly talking to informing that. So this is the same, but this talks to the high MDR, multi-drug resistant. I will have to speak a bit slower now. Multi-drug resistant setting as well. As we did mention that in with multi-drug resistant, obviously, after we had ran the first test, the primary test, you are reflexing now to run a second test to check more on what more once this is the multi-drug resistance or the MTB RIF is positive, you can reflex and check on the other antibiotics that the patient is actually resistant to, so that they can inform if you need to go on second line, is the patient also resistant to second line or not. So this is one of the clinical pathways that talks to the high MDR or rifampicin resistant settings. So yeah. So there's different tests for different circumstances. As long as we all know that the first line, it has to be MTB-RIF, it's gonna give us those results. Then from there we can go to, as you can see, the expect the test that is projected on the slide is the MTB-XDR. So it's slightly different in the phrasing compared to the previous one that's written MTB-RIF. So yeah, that this is a reflex to the initial one. So on high MDR setting, of course, WHO recommends the moderate complexity nucleic acid amplification test and targeted next generation sequencing for diagnosing TB and drug resistance. This enables centralized lab to guide individual treatment, especially in MDR high burden settings. So of course you will need a full phenotypic drug sensitivity testing to inform the treatment that we're actually using. So in most cases, when it gets to like MDR, most settings will be using the centralized system rather. But as long as we all know that it's possible, especially with GeneSpect, you are able to run, you have same cartridge that's for MTB-RIF, and you have another cartridge that's for MDR, but also in decentralized or rather in centralized settings, because the first one is decentralized settings. So you're able to test everything wherever you are. But if you're still using the centralized setting as well, you are able to ensure that the patients are detected accurately as long as we are following this algorithm by the WHO. So now looking into, because I think the previous slide, I focused mainly on the MTB-RIF, which is the first line, right? The first line GeneSpect test that detects TB. It's going to tell you if it's rifampicin positive or negative as well. If it's positive, you reflex to this one. So when we go into this one, which is MTB-XDR, so this one is a reflex test, is never the first line. This is after the MTB detection, so that you can identify the resistance to this one. Is going to give you more, not just rifampicin like the first line. This is going to go into giving you more into even isoniazid, ethioimodal, and the fluoroquinolones, and second line injectables as well. So it gives you so much more. It's going to inform your clinical decision to say how I want to manage that particular patient. And you running the sputum or from the culture. So it's supporting rapid diagnostic of XDR-TB directly from sputum or culture. So you can run with either of those specimen types. So there's evaluations that are being conducted, and that's how as well, we need to regularly check the accuracy and the performance of the test. So this is an independent evaluations that shows that they expect MTB, XDR particularly, reliably detect key resistance mutation, including the fluoroquinolones. I'm going to be cautious and make sure that I breathe before I call it. And ethambutyl isoniazid second line injectable, obviously, with strong performance even in heteroresistant samples. This is supporting, obviously, its role in the rapid expanded drug resistant profiling. And remember, because the GeneSpect is automated PCR, you can run them from almost wherever. So it remains superior in a sense that it's going to give you the results that you need and that are going to inform your clinical decision and the treatment that you must give that particular patients. So these different evaluations, they looked into the analytical performance of this XDR testing just to ensure that the level of detection of MTB as well should be accurate, right? It should be accommodative enough to the lowest, even the lowest, say, bacterial load in the sputum, and the accuracy of the detecting the mutation, because we know that, these bacteria or these bugs, they mutate over time. So we need to ensure that it actually targets different part of the gene of this bacteria that we are talking about, so that we maximize detecting and not missing or giving false negative. The last thing you need as a clinician is to have a test that gives you false negative, and then you are sure that the disease is not there, whereas we are actually running a risk of vertical transmission or forward transmission or whatever case it may be. So we need to be confident in a test that we are using, that really the true case is being detected and the negative is truly the negative test. So these are the evaluation that just ensured and giving more confidence to say this test is good enough. So in summary, as I go, so to achieve the TB elimination, which I hope it should be everyone's obsession like it is to me, we must target the high burden pockets, because we know that geography or epidemiology is not the same, so we have pockets of high burden, especially the high burden countries like South Africa. We're carrying the highest burden of HIV, hence the highest burden of TB as well, since they are bodies, so we need to be using the recommended repeat diagnostic test that ensures accurate, cost-effective, as well as capable to detect the drug resistance across diverse population as well. So the test must be good enough, but also in across population, like HIV population or your children as well. So it has to be a good enough test that ensures the health security overall. So that's just about it with my presentation. I tried to be as short as I could. Thank you very much for listening.
Mm-hmm. Are you now short? You said you tried to be as
Almost.
short as possible, but I think when you started, you said it's going to be short, the opposite of who you are. So I assume you are quite
Yeah,
tall. No,
I
no, no.
am
Thank
quite
you,
tall.
thank you, thank you. I think we rarely get talks that finish on time. Most of the people who teach here, they really use the time such that we tend to not have enough time for discussions and engagements. So I really appreciate that, because we really learn during this particular time. Yeah. So thanks, colleagues. Maybe what I can do, since we have a little bit of time before we take the questions, I'm just gonna play that Dr. Ryan ECG thing just for you to rethink whether you are joining us this weekend. And immediately after that, I'm sure Unqobile would have taken her sip of water, and then we will then go through some of the questions. I'm very excited. Let's go for it.
So it's time for us to see this in action. A beautiful 12-lead ECG, right? We're going to take about maybe 5 seconds just to stare at this ECG and try and decipher what's going on. All right. So here we have it. List the main abnormalities. We see beautiful ST elevation in the inferior territory. 2, 3, AVF. Boom. Very nice. But that's not all we see. We also see ST depression with inverted T waves in lead 1, right? We also see it in AVL. There we go. And in V2. Hello. This is what we call reciprocal change, right? We are infarction in one area, and looking at the heart from another angle, we see ischemia. We took that same ECG and we flipped it around, right? And if we read this ECG from right to left, then what was ischemia, as in 1, AVL, and V2, now looks like ST elevation myocardial infarct. If we look at what was infarction in 2, 3, and AVF, if we read it from right to left, now looks like ischemia. That is the beauty of the electrocardiogram, because guys, we're looking at the same heart, but from different vantage points. Hence, we use the term reciprocal change. So this is an inferior myocardial infarct. But in the anterior territory, we have ischemia. That's reciprocal change coming from the inferior event.
Mm-hmm. We are discussing gene experts, and I'm showing you ECGs. If you got stuck somewhere in those graphs, join us on Saturday so that next time you are really looking forward and you can interpret all those things. Yeah, Nobile, if your video allows, you may open it, but otherwise, if your network is still a challenge, it's still okay. There's a number of questions, but maybe before that, just to inspire you, there's a lot of positive feedback. You can see Abdul says, thanks for the excellent presentation. David Kumalo says, thank you, Dogotela. Wonderful presentation. Someone says they will join on Saturday. I'm just looking for feedback at this time. Yeah, Renelo says, thank you. Very interesting, great presentation. Yeah, so maybe let's go through then some of the questions. There's a trending question which I saw at least 3 or 4 times. I don't know if you know about the concept of TB NAT, NAT and colleagues, NAAT, nucleic acid amplification test. Because people are saying, which one must we use, TB NAT or Gene Expert? I don't know if you know about the TB NAT, because it's the Department of Health has transformed the language a bit. Maybe you can comment, then I can add in that space. Thanks. Yeah.
Yeah, I would love it for I love for you to add. So the NET is, as you have said, is nucleic acid amplification test, and under the NET there's different technologies. GeneXpert is one of them, so it's not two different things. It's just that I call it by name. So there's other names that or other companies that have manufactured machines or technologies under the NET. So the difference is across any type of test. In this case, we can talk about the NET overall. So the differences will be the performance, for instance. We know that we want to, as clinicians, we want to know the sensitivity, the specificity, the positive predictive value or the negative predictive value. In this case, I spoke about the genetic coverage. How many gene targets does a test target and cover when you stop speaking about that particular bacteria. So there's characteristics that we use to describe different tests. So GeneXpert is not different at all. I understand that currently there's, I think it's 3 different NET technologies that are being used in South Africa or in the public sector. But yeah, I hope I answered. You can
Yes.
let me know.
No. I think you have covered it very nicely. Colleagues, when I grew up, all toothpastes, I used to call them Colgate. What about you? And all, I don't know, is it roll-ons? I used to call them Babrol, So there's this in-house name that we use. So Gene Expert, the word or the term itself is what we have traditionally used to refer to all DNA or PCR-based diagnostic tests. But after WHO introduced, especially 2 additional tests, your BDMax and also the machine from, I think, Roche or something like that, we then had to really have a proper name for these diagnostic tests. And I think Ungwabile has explained it very nicely. TB, nucleic acid amplification test. These are DNA PCR tests, really, like any other PCR test that you do out there. And these machines, there's 3 types of machines. There's your Gene Expert machine, there's your BDMax, and there's your Roche. In South Africa, just maybe to clarify as well, it's only the Gene Expert machine which has been approved to process non-pulmonary, pulmonary and non-pulmonary specimens. The other 2 machines are only approved for pulmonary specimens. So if you want to do, for example, TB in the stool, TB in urine, the lab will probably process using a Gene Expert machine. You won't know unless if you pass by your lab and ask them which machine they have, because if you collect TB stool and maybe they have a BDMax machine, for example, it means your specimen may be referred to another lab just to process that non-pulmonary specimen and get your results. It should be quick, but it may affect maybe your turnaround times for your results for maybe a day. I don't know the issues there. But I saw we have my dearest friend, Mr. Ngwenya, Themba Ngwenya. Mphathi wami, He's our head of DRTB at Gauteng. There, I worked with him. It was very nice in that September. Let me know if you want to say something live just to hear your voice. But he did make a comment to say, we will continue holding hands in the fight against TB, especially, I knew he was going to say, especially drug resistant TB, maybe trying to show without showing that his corner is not just TB, but it is this particular TB. So he's our provincial DRTB manager for Gauteng province, right? Hey, people asking about the diplomas. Let me pass very quickly. Slides. No, let's not respond to slides. So slides, we don't usually share slides, colleagues, but if you are a member of this platform, you'll get access to the micro lesson with the recordings. And if we get permission to share the slides, we also keep them there secured so that we do not overuse them. Let's look at this one. Mangaliso says, good presentation. I think he's trying to ask you but now is the XDR1, but maybe you can respond to two levels, right? For the expert for drug sensitive TB versus the MTB XDR, and which is something I didn't clarify, but I think colleagues will get that there's two kinds of expert machines. Where are they placed in South Africa? In Nqobile? Are they placed at the end user, like let's say PHC in the labs? I'm sure this is the question. It says in the level of care, lab tie.
Yeah,
Maybe
yeah.
it's your language, this lab tie thing. You can respond and let me know. Yeah.
So what I know from the CFID side is that our gene expect are widely available, not just in South Africa. Every country actually is a leading global diagnostic in the technology. So even in South Africa, it's decentralized such that I believe almost every healthcare facility has a gene expect machine. As you remember on the slide that I showed, the different sizes of the same machines just comes in different sizes, depending on what level of care employed what test. So I wouldn't know exactly at your health facility what size do you have. But I know that every facility, as long as you are running a gene expect, as long as you're running your TB test, you should have, particularly at the district level. At the district level. So you can, I cannot assure you right now where I'm sitting, but you can always check with your facility on, I don't know, the person who's asking, are they at the district hospital? Are they at the primary hospital? So yeah, but I know that it's widely available, particularly up to the district level.
Yeah. The only thing
So
I can...
I think
Yes. Continue.
the question was, where do you run the?
Yeah, he's asking where the machines placed, but he has specifically mentioned expert MTB XDR, which are generally centralized. So maybe the only thing I can add to this question is when the expert machines were initially introduced, the goal was to make it a point of care TB diagnostic test, because you can actually process and get your results in 2 hours time, and depending on the size of the machine, some machines can take a lot of cartridges, etc. But we know with lab issues, there's issues of quality assurance. So South Africa couldn't put in place a quality assurance system to support, let's say, nurses, to run these specimens and assure, let's say, the patient that the quality of the result, can be trusted. So these machines are still centralized at labs, but most labs are decentralized anyway, because most district hospitals do have local labs. Some big CHCs do have local labs, but then the processing will still be done by an experienced lab technician. So we should say that we have access. Basically, we have extremely good access. Actually, if you look at the targets for what is this plan, TB recovery plan, you'll find that we are not achieving the number of tests that are supposed to be done on an annual basis, because there's huge targets to try and find people living with TB timely, etc. So I would actually answer this by saying we have good access. It's a question of you know, do we have enough people to be tested? And that is a question for us as health workers in terms of identifying high risk people who need, you know, to get this specimen. And maybe some of the discussions, which is some of the questions I had for you, we can get to them later once I feel like we have responded to all the questions from the audience. So we will come back to that now. Let me see. I think because I was talking, I missed. Okay, someone was talking about. Yeah, I think this question will probably talk about TB NAT versus Gene Expert. And Babekile says in the adult primary care guidelines from government, which are the recommendation is to use TB NAT, right? Has TB NAT replaced Gene Expert? Tembo guy, I hope he can see the confusion. It's like a
Yeah,
TB NAT is another test,
a different
which
thing.
is
Yeah.
and all. That's why I said there's a trendy question, you know, and then they say I also noted that TB NAT result would reveal the results of a client if the client is INH resistant, which is good. Is TB NAT better than Gene Expert? Maybe you want to re-clarify.
Okay,
You
so
want to re-clarify
yeah,
this.
yeah,
As I find
yeah.
Temba,
Okay.
I hope Temba, if you are in a good space to talk, let me know. But any other TB person can give
Yeah.
their time. Yeah,
Oh, but
thanks.
Tamba should come to my rescue. So basically, the TB NAT, I mean, NAT means nucleic acid amplification test, right? It's not gene expect, for instance, only, or the Roche that you spoke about, or PDMX. So both you have TB NAT being an umbrella of all these tests that are running the molecular diagnostics. So as I've said, the difference is that perhaps it will be the guidelines or the availability of the test in your lab in that particular hospital, right? I wouldn't know what exactly are they running, right? But the expert or the gene expert that I'm talking about is a NAT itself. So with the difference, she mentioned something important to say. The TB that she knows, it has also she
INH.
mentioned about resistance, INH, whereas the one I was talking to, it mainly has the rifampicin. So that is correct. So what happens is that the WHO recommends that the reason why it actually promotes the gene expect to be the primary net for TB is because once you have resistance, you need to reflex to check on the wider coverage of the resistance to the second line. Yes. So it talks to the clinical action that you have to take. So the isoniazid is good, you can have it, but in terms of the clinical action that it will inform, I think you'll still have to reflect on it as well. So just to say they are all net systems. Yes,
Yeah.
they all have their pros and cons, but I've said you can look into the characteristics such as other things, the clinical action that you have to take, the resistance detection, how wide is it able to cover the gene targets of that bacteria, and most importantly, is it WHO pre-qualified? That talks to the quality of the test. So that's the important thing that you need to also think about, and also well as the performance, of course. But they are all basically under NAT.
Okay. Thank you. Yeah, I see in that Temba you have unmuted. I don't know if you're able to talk before I add my comments.
No, good evening, colleagues, and thank you, Dr. Mawela, for the welcome, and thanks, Ngobile, for the good presentation. No, I just wanted to weigh in on the TB NAT versus the gene expect. Colleagues, we are talking of toothpaste and Colgate, Dr. Mawela. we were introduced to TB NAT, to gene expect before we could be introduced to TB NAT. Now, we are carrying on with the gene expect, even though sometimes we are referring to the TB NAT. But basically, TB NAT is the umbrella, and then all other tests fall within the TB NAT umbrella. It depends on what lab you are using and what machines do they have within the lab that you are referring to. But it also talks to what Mengobile has said, to say if the rifampicin is resistant, definitely it will spread to test other, to find out other resistance patterns that the patient might be having. But yes, with the introduction of the TB NAT, we've also seen an increase in INH resistance, which will come back with a sensitive rifampicin, but INH will be resistant. So we appreciate the introduction of TP-NAT because at least it has explored various tests that we are identifying. Thanks, Dr. Mawela.
I mean, I was not even listening. I was just happy to hear your voice. I'm so happy that you sound good. Thank you. Thank you. Thank
Thank
you.
you.
Maybe colleagues, if we go back to just to clarify, because I think you'll get stuck. You see, the question by Mangaliso says expert MTB XDR, right? So firstly, you have your TB-NAT. Under TB-NAT, currently South Africa, you've got three sort of PCR or nucleic acid amplification test. One of them is an expert machine, BDMax, and the one by Roche. I forgot if they have a unique name. Now, your Roche and your BDMax also process INH resistance in addition to RIF resistance. But like I said, they are only approved for respiratory specimens. That's you keep it simple like that, right? If you use any of these three machines for a new patient, and the results come back and say Mycobacterium tuberculosis detected, and there is a resistance, right? Let's say RIF resistance in this instance. You will collect another sputum or smear for this test that you're looking at your screen there, expert MTB XDR. This is actually, you just say reflex test, to be honest, right? The lab will do a series of tests. One of those tests is a smear, 1 plus, 2 plus, 3 plus, that type of a result. They will do a phenotypic culture, grow TB, on a culture medium, like the old way of growing. But they'll also do what we call genotypic resistance testing, which is done immediately for your fluoroquinolones, right? Why? Because we have a drug a regimen called B-PAL-L, which we use with a levofloxacin there. So we want to see if your patient has quinolone sensitivity or quinolone resistance. When I say genotypic, it means it's a TB-NAT, but for second line drugs. It means you are able to tell within 2 days or so whether your patient, in addition to RIF resistance, also has resistance to your fluoroquinolone, so that when you give B-PAL with an L, you decide whether you are going to have levofloxacin or not. The same applies if they use BDMax or Roche machine and the result says rifampicin is sensitive, so there's no RIF resistance, but there is monoresistance to INH. The algorithm would require that you send another specimen for a reflex test, because in South Africa we treat INH monoresistance with RIFA4. I don't know my screen, with RIFA4 plus levofloxacin, right? That's how we treat it. So you give your patient RIFA4 plus levofloxacin, you do your reflex test, you want to check that this TB is sensitive to levofloxacin. That's why you're doing the reflex test. If it comes back and it says levofloxacin or fluoroquinolone resistance, it means your patient needs to be referred to a centralized site to be evaluated and for an appropriate treatment to be given, because RIFA4 plus levofloxacin won't work. There's levofloxacin resistance. So that's how you'll get confused. So I was trying to show you that there is an expert machine which is done on all people where we suspect TB, but there's also an expert machine, expert MTB XDR, which is done when you have now confirmed resistance and you want to evaluate sensitivity for your second line TB drugs, right? Plus, but please don't forget, we've got toothpaste. Some of them is Colgate. Gomilo, which one do you use? What's your brand? If it's not Colgate, it's what? I don't know. Aquafresh.
It's co-
Yeah.
yeah,
So TB
fresh,
that is like
it's
only
one of the
the
Colgates.
yeah, it's like Colgates, TB nut. But then which one specifically are you using? I don't know. Colgate, Aquafresh,
Sensodyne,
yeah, all those kinds of things.
White Glow.
White glow. Okay. So awesome. So let's go for some of the questions. I saw a question by Samuel. Let's look at it. I'm sure it's an interesting question. Samuel says, how long do patients with MDR TB, how long should they be isolated after starting BPAL-M? So Samuel, you must tell us which country you are joining, because I can see you are using the one in the studies, BPAL-M. So bedaquiline, pretomanid, linezolid, and then moxifloxacin. Because that's why South Africans will say, hi, BPAL-M. No, BPAL-M is Moxi, but we use a level, right? So, but it's the same. So I'm asking because so many doctors keep avoiding such cases, even when they are on treatment, as they have seen MDR. Yeah, so there's a lot of stigmatization and discrimination. I don't know, maybe it's a clinical question. You can try and respond to it, but as soon as the smear is negative, to be honest, we shouldn't be worried about, because people who are smear negative are less infectious. Nobile, would you like to add to this one? Hi, Nobile. You are muted. I'm sure you are talking. You are muted. Okay, I can't hear her. Nobile, find the mic sign and unmute if you are able to hear me. But Samuel, just to say that for DSTB, we expect many patients to be smear negative by 2 weeks. But remember, our RRTB patients take a little bit longer. So I will just say, as soon as you have your first negative smear, not necessarily culture, but your first negative smear, you should be good to go. And it's variable, I won't say 2 weeks or something, but it will be a minimum of 2 weeks, I suspect, right? Nobile, let me know if you're able to hear me.
I am able to hear you. So yes,
Yes.
I would add on what you just said as well, to say as soon as the smear and the clinical status of the patient, the severity of disease as well. So you take into consideration all of those. As soon as the smear is negative, then you could consider it's not an indefinite isolation, but yeah, you review.
Okay. We lost you there at the end. I don't know if your network is challenged. Dr. Francisco says, good evening and thank you for the
Yes.
nice presentation.
I think
Yeah, can you hear me?
yes, I can hear you. Can you hear me now?
Yes. Dr. Francisco says, what about the risk of false positive RIF resistance results with gene expert ultra, especially the samples with low bacillary load? Okay, so it's asking about your test and then also the possibility of false positive results. I don't know. You are muted again. I don't know. You probably have a network challenge.
Yeah. I still I have the network challenges. I'm walking around. So that's a very good one, Naga, and I think it's what I emphasized when I said the different tests. It depends according to their performance. You definitely want to know how good is the performance, especially in this case, the level of detection and the postulate. How is it able to actually identify and still detect the gene or the TB itself on the low bacterial load? So the gene expert is known to have a very high sensitivity, of which is the reason why it's pre-qualified or WHO recommended, because it's able to detect.
Yeah, we lost you again. Okay, I think we'll.
Even there is viral bacterial load of.
Okay, I think we have a network challenge with our speaker. Dr. Francisco, I think there's many things that play a role there, right? Besides whether there's resistance or not. I think the key thing is to understand that the current protocols, especially here in South Africa, that we are using, will always have that small chance of a false positive result. Why? Because traditionally we would screen people for symptoms of TB. If they have TB symptoms, we would then do, a TB diagnostic test, a TB NAT test. So we kind of like have symptoms, right? Let me move this side. We sort of have, symptoms, and then we are doing a test. But today's screening protocols, there are specific patient populations which are regarded to be at a higher risk of TB. These populations of patients, we would conduct a TB NAT test even when they don't have TB symptoms. That puts us in for a clinician who understands the role of a high index of clinical suspicion before you do a test. You will understand the complexity there, that we are running a risk of one or two people whom we are screening who might have a result that is positive even when they don't have the disease, right? Now, there's few things how you can approach that. Number one, if your TB NAT result comes back positive, you have to try and find a clue. Usually, if there is TB, you will find some lymph nodes. You'll really find that the patient does have some symptoms, even if maybe they initially thought that these symptoms, were not significant. So that's number one. The second thing, you might have to evaluate if your patient has had TB in the last 2 years, because TB in the last 2 years may also mean it's a false positive result from dead TB bacilli. Very, very important. And if you are still very, very worried that you think your patient does not have TB, then you might need to do culture, because few things about false positive results. A false positive TB or a dead TB bacilli doesn't make people sick. So if there are symptoms, they probably have TB. It doesn't grow on culture because it's not alive. So if it grows on culture, it's probably alive, and you should treat. And the third thing is that the resistance profile doesn't change, right? So if your previous result, your patient had INH let's say INH was sensitive, and your current result says INH is resistant, even if the patient had TB, let's say last year, this is new TB because the mutations, it was previously sensitive, it is now resistant. So if a patient meets any of these three criteria, you should probably treat your patient. But all diagnostic tests, whether HIV test or test for malaria, have that risk, especially your initial test. If it has a high sensitivity, it has a potential to give you false positive results, and your specific results may give you a little bit of a false negative result. So it's part of the weaknesses of the test we do. So we should always interpret this test in the context of how our patients are presenting clinically. So this is very, very important. Yeah, I see a lot of okay, up here, NAT versus GE. I think you're saying gene expert, ne? I think there is supposed to be an expert, but up here, if it meant something else, do let me know. I think we have exhausted the issue of differentiating between the two. We were told in other forums that the sensitivity of gene expert XDR for the detection of MTB was lower than the sensitivity. Yeah. They are not the same. It's a little bit lower, but it doesn't mean. And remember, if the sensitivity gets lower and lower and lower, you are likely to now get false negative results. And that's why it's used. That's why the gene expert MTB XDR, it is not used as a first line diagnostic test. Remember, generally speaking, when you have 100 people and you want to find out who might be having the disease, you use a test that has a high sensitivity. Let's say the sensitivity is 98%. So that's very high, or 99. That's very, very high. So it means if they all have the disease, and if it diagnoses 100 people, there's one who might be a false positive result, right? Because it's a test that has high sensitivity. But our second test that we do tends to be a test that has a high specificity, right? Which is unlikely to be positive unless the person has the disease. And we don't use them as first line, we use them as a second line. We usually call them confirmatory tests, and that's how we use it. Remember, your resistance profile, particularly for RIF, you would have detected it not with a XDR test. You would have detected it with a Gene Expert Ultra, which we use as a first diagnostic test. I don't know if Nobile is back to respond with me through some of the questions.
Yes.
Like it is a topic
Yes,
I understand. I think if this topic was about
yeah.
TBGs, I would be finished.
Yes,
Okay.
basically, you are saying it right. I think it's according to the purpose. So the GeneXpert XDR is for XDR, is not for primary TB,
Diagnosis.
the way you're saying the first line.
Yes.
So the first line,
Yes.
we say it's expect a TB RIF Ultra. So
Yeah.
that's the first line. So that one is not meant for that purpose. So it's mainly for drug resistance, and it's a reflex test, the way you said. Sure.
Yes, yes. So Lubabalo is asking, is Gene Expert for both respiratory and non-respiratory samples? Would you like to respond to that? Colleagues, we will finish in the next 5 minutes. I mean, there's over 600 of you, so we don't want to disappoint you. We are just going through the questions, but in the next 5, actually before 8, as per the advertised time, we will finish. So we are just going through your questions. Thanks for you still being here. We appreciate it. Nqobile, can you respond to this one then? Gene Expert, respiratory versus non-respiratory symptoms. Yeah.
So the on-label use for Gene Expect, according to the labeling of the manufacturer, it says the sputum. It talks about the sputum, but I'm aware that I mean, in many places, even on all these other guidelines, they are able to quote it on how they have been used it, and they have validated it for other specimen types. But now I can only talk to the on-label and the off-label use, which would be extrapulmonary. There's a specific team that talks to that, which is just not myself. I'm able to obviously refer you to the team in-house that can take you through that part. But as you can, I can tell you that I mean, we have publication all over. It's just that I'm for restriction purposes, I'm not allowed to talk about extrapulmonary. There's a specific team
Yeah,
that
but you are you
go
are
for
you
that.
are in South Africa, so I will respond to that because it's in the
The guidelines in
guidelines.
South
Yeah,
Africa,
yeah,
exactly.
it's in
Yeah.
the guidelines. We do it on CSF, and now there's even a guideline published 2 months ago talking about urine testing using Gene Expert, and then there was also an official communication by the National Health Laboratory, and that temper remind me of stool for children. Is it less than 8 or less than 10 years? That temper, you can remind me the age there that you're allowed to do stool specimens. If you have a lymph node, you can send. So to be honest, we use it. We know the yield, the specificity. I mean, the sensitivity is low. So those tests are only good when the result is positive. When they are negative, you cannot necessarily say there's no TB. So they are quite useful in that space, right? Yeah, see, I saw 2 questions. I think I saw Velemse as well, talking about MEG and stuff. So this one has got nothing to do with molecular testing. It's about MEC. So who gets MEC? It's people who are immunodeficient. In my world, the HIV world, it's a very important non-tuberculous mycobacterium happening in patients with severe immunosuppression, especially if the CD4 count is less than 50. They tend to be very sick. Intra-abdominal hepatosplenomegaly, lymph nodes. You must remember Mycobacterium avium complex is a opportunistic infection. So if you find it on sputum, it doesn't mean much, unless if you can see, you can have serial cultures showing growth in a sick patient, then you probably have to treat your patient. We treat it by also adding your macrolides, azithromycin or clarithromycin, but nowadays azithromycin is like the preferred one. So these ones you diagnose on phenotypic culture. So you must take your specimen, a sterile specimen, CSF, blood, urine for culture. If you grow MEC on a sterile specimen, not necessarily on a sputum, and it grows there, you probably have to treat your patient. The treatment cannot be stopped for at least a year, and your patient must have the immune system must have recovered in terms of the CD4 count. Yeah, so Dr. Temba is responding to that question to say on BPAR, when can we say it's safe? It's a minimum, of 2 weeks. But your best bet is when that 2 weeks smear is negative. You sort of have the confidence. So yeah. Thank you, Dr. Temba. I think I appreciate that. Mangaliso says I'm joining from Eswatini. Welcome. We are a global platform, colleagues. Let's hit that horn. I hope it's not too loud for the night. Kimutu is asking about urine lamb. Ncobile, you didn't tell us, Safed, whom are you providing the machines to? Ncobile, hi. Can you hear me? I don't know if she can hear me. Hi,
Yes, I
Ncobile.
can hear you, but I lost you. You were
Yes.
off for a while, so.
Yes, yeah, you have a network challenge there. I was asking, there's a question about urine lamb. And then I was also asking, it seems like you provide these expert machines. I wanted to check whom are you providing the machines?
Provide, they are being bought. Well,
Oh,
from
you
the
are selling.
there's I think for that purpose I will have to we'll talk about it off this platform. I'll have to connect with the people that works with that type of thingy, but I don't think it can be provided, but there's a way to get it because
But all I wanted to confirm is that you are the supplier of the machines, basically.
of course,
Okay.
yeah, we are the
And then
supplier of
urine
the
lamb, is it also one of the diagnostic tests you provide? Because there's a question about it.
No, we're providing basically the Gene Expect and the Expect Ultra in the context of TB, the XDR as well. Yeah, we're not providing anything beyond that.
Okay.
Especially for other specimen types, we don't provide anything of that sort.
I hear you. So Kibuti talks about the urine lamb, not lamb. Now you make me hungry, Kimutu. If it's the lamb, ooh, medium well. Yeah, but urine lamb, colleagues, again, it's for patients with HIV who have advanced HIV disease. That is a CD4 count less than 200 cells, or WHO stage 3, stage 4 disease. If they are ambulatory, a patient who maybe you see them in outpatients, they need to have TB symptoms before you do a urine lamb. If they are very sick and they present to a hospital for admission, you have to do the test regardless of symptoms. So that's how we deal with that. Okay, we have the last two questions for the night. Justin, I think I responded to your question about mycobacterium other than TB mods. We cover this topic in detail in the HIV diploma preparatory program. So I'll see. I'll talk to Dr. Lauren to come and give us maybe that summary talk here, because it's a common question, so that we can have clarity. So expect that in September, there's a chance that we will cover a mycobacterium other than TB. Yeah. And at that time, my savior there, hey, we used to work nicely together. When you were there, I would always say, Temba, help me. So he says, for testing tools for TB in children, they should be under 10 years. Yeah, colleagues, we really survive on relationships and collaboration. That's why we call this home of yours the clinical care platform. Nobile, if you can hear me and your network is good, I would love you to say your closing remarks, and then we then close the webinar. Thank you. Nobile?
Yes, I'm here.
Okay.
Thank you so much for having me. And I'm glad that it actually stimulated the conversation about the net. I know that diagnostics are not really part of what we talk about much as clinicians. We know we write to and we leave it to the lab to actually do it for us. So I love it when we get to speak about it and we get informed on what to order, exactly what to write it, for what purpose and in what context. So yeah, I'm pleased to be here, and thank you so much for your engagements as well.
Thank you. Thank you. This was very enlightening. And I also want to thank Mr. Ngwenya for chipping in, for helping us with the questions in the chat, but also responding live. We really appreciate all the colleagues as well who helped with answering some of the questions. I saw Pepelo saying, I think that it's mainly due to the quality of the specimen. That's why you may get false negative results. We are a community, there is no expert here. We can only learn from each other. I was reading today about curiosity, that we need to learn to be curious people and not to be people who have answers. And if you are curious, you just ask questions and allow people and learn from other people and get empowered yourself. Colleagues, before we close, in the chat, I have shared a link for our WhatsApp group. If you would love to get timely updates about our events, don't miss Thursday. Thursday, we have an interesting dermatology webinar on connective tissue skin disorders. Ooh, clinical care platform. Catch us if you can. I don't know if you guys know that movie. I'm disclosing my age. And then also, I'm sharing, if you are interested to join our membership program, let me share that particular link with you. And the last one is the upcoming ECG masterclass. If you want to learn what those graphs mean, those graphs can be life-saving in ICU, high care, theater, emergency, anywhere basically. GP practice, you can put those electrodes and boom, you have a diagnosis and you are able to help your patients. On that note, let me wish you a good night as I close this webinar with Dr. Ryan again on the same ECGs. Night, night.
So it's time for us to see this in action. A beautiful 12-lead ECG, right? We're going to take about maybe 5 seconds just to stare at this ECG and try and decipher what's going on. All right. So here we have it. List the main abnormalities. You see beautiful ST elevation in the inferior territory. 2, 3, AVF. Boom. Very nice. But that's not all we see. We also see ST depression with inverted T waves in lead 1, right? We also see it in AVL. There we go. And in V2, hello. This is what we call reciprocal change, right? We are infarction in one area, and looking at the heart from another angle, we see ischemia. We took that same ECG and we flipped it around, right? And if we read this ECG from right to left, then what was ischemia, as in 1, AVL, and V2, now looks like ST elevation myocardial infarct. If we look at what was infarction in 2, 3, and AVL, if we read it from right to left, now looks like ischemia. That is the beauty of the electrocardiogram, because guys, we're looking at the same heart, but from different vantage points. Hence, we use the term reciprocal change. So this is an inferior myocardial infarct. But in the anterior territory, we have ischemia.
Missed our latest webinar? No worries. We know life gets busy, but your professional development shouldn't have to wait. That's why we've created webinar micro lessons. Short, focused recaps of our full sessions designed to help you catch up quickly and still earn your CPD points. These bite-sized lessons are available exclusively to active subscribe members. So even if you miss a live session, you never miss out on the knowledge or the CPD points. Not subscribed yet? Now's the perfect time to join. Get access to all future webinars, every micro lesson, and more. Visit www.clinicalcareplatform.com to sign up